My apologies. Good evening, Madam Chair, members. I'm Dr. Savitri Fedson, and I'm here representing both myself, my patients, and the Texas Hospital Association. When I'm giving you, I'm actually going to deviate a little bit because I do want to clarify some things that have been mentioned. But just to give you perspective of who I am, I'm a professor of medicine at Baylor College of Medicine, and I'm an advanced heart failure and transplant cardiologist at the Mike Lee DeBakey VA Medical Center, where I also run the ethics committee at both Baylor St. Luke's and at the VA, and run their consult service. As far as a cardiologist, I am the chair of the American Board of Internal Medicine Exam Rating Committee for subspecialty boards for heart failure and transplant boards. And I'm on the clinical right guideline statements for American College of Cardiology, American Heart Association, Heart Failure Society of America, and the International Society of Heart-Lung Transplantation.
In your position on the bill?
Oh, excuse me, I'm opposed
Thank
to
you.
the current bill. Thank you. So as a physician, I routinely care for patients who have a 50% chance of surviving 2 years. These are people with critical ischemic heart disease, valvular heart disease, but heart failure. And often, in order to see what options I might be able to have for them, I have to see if they might be a candidate for an LVAD, the type of pump that Dick Cheney had before he had his transplant, or indeed get a transplant. In order to get there sometimes, I need to give them technologies to make sure that the ultimate treatment will actually benefit them and not cause them harm. And to that end, I just want to clarify a statement about the definition of life-sustaining treatment. The definition of life-sustaining treatment is not only a ventilator. The definition of life-sustaining treatment, according to the Texas statute, is any intervention that will sustain the life of the patient without which the patient would die. That would include dialysis. That would include chemotherapy. That would include ECMO. All of these would be considered under the statute's forms of life-sustaining treatment. And I think that's very important to talk about because there are no place for indefinite or indeterminate care at this point. We are not, generally speaking, simply talking about ventilatory support. And I think the cases that have gone to the 046 are not simple cases about ventilatory support. We're not talking about the classic tracheostomy and PEG tube. There comes a time with medical conditions when our efforts to cure or even temporize the disease have more harm than benefit. Recognizing the limitations of modern medicine technologies recognizes that dying is not a failure of medicine. It is ultimately the inevitable end. There comes a time when the therapies and interventions we have at our disposal cease to prolong life, or even the patient's chosen quality of life, what they would like. It ceases to be able to maintain what a patient would want. And it only prolongs the natural dying process or even violates patients' indignity. Let me also add that with our ability to have these life-sustaining technologies, with the exception of liver support for end-stage liver disease and skin integrity, we have the ability with life-sustaining treatments to essentially make it impossible for patients to die naturally. It is very difficult to declare brain death on someone on ECMO because of the way brain death is defined and the type of support it does. So these life-sustaining treatments ultimately, and with all due respect, yes, we want patients to be able to die naturally, absolutely. Maintaining this level of technology impairs our ability to actually allow patients to die a natural death. It is incredibly difficult to let a patient die these days with the type of support that we have. And one aspect of this bill that helps with the family is that it gives them a way to let the patient die naturally. Medical technologies does wonders, but does clearly do harm. During the past year, we have seen the emotional toll this has taken on our providers. We have felt their moral distress, absolutely. Nurses especially are leaving the field. Our scarce resources has actually not been ventilators, but people. Our scarce resources are the people to care for our patients. And these nurses are leaving and they aren't coming back. Not allowing professionals to provide compassionate care by demoting them to the role of a technician at the demands of the emotional demands of family wishes is a disservice to their commitment to the patients and their disservice to their service to healthcare. The decision about appropriate treatment should not entirely override professionals' opinion of those to care, to understand the complexities and care. And these include our health professionals, our ethicists, our chaplains. They are trained professionals who could take the most recent data and the most recent studies that may say this is an appropriate option for the new treatment of traumatic brain injury. Our professionals are the one who are going to know if that's appropriate. Those are the people who are trained to review the scientific material. I hope that you vote against this bill. Our trained professionals need to be the ones to help determine this. With all due respect, families feel loss and sorrow. Providers, too, feel loss and sorrow every time they lose a patient, for every patient they have touched, and they have to go home and then they have to come back and do it again. Allow physicians to use their medical judgment and do not force them to indefinitely intervene in the dying process. Do not force them to prevent a natural death. Help preserve the dignity of patients, yes, but please help preserve the dignity of our healthcare professionals. I'll take any questions. Thank you.
Questions, members? Thank you.
Thank you.